Documentation alone does not improve outcomes. Clinical oversight does. And that's one of the biggest reasons many chronic care management programs fail in primary care today. Hi, I'm Natasha Jackson, a registered nurse and care management strategist. I help primary care practices implement nurse led technology supported care management models that improve patient outcomes and generate sustainable practice revenue. Let's talk about why many chronic care management programs fail and what primary care practices are getting wrong. In most cases, it's because the program was never structured correctly in the first place. Many practices enroll patients into chronic care management programs, but they underestimate what it actually takes to manage patients living with multiple chronic conditions. Patients with diabetes, hypertension, heart disease, and other chronic conditions require ongoing support between visits. They need someone reviewing medications, creating and reinforcing care plans, monitoring symptoms, and identifying risks before those risks turn into hospitalizations. Chronic care management was designed to provide that support, but the success of a CCM program depends entirely on how it is implemented. One of the most common mistakes I see in primary care is how practices structure their staffing around chronic care management. Many practices attempt to run CCM using medical assistants without a clearly defined clinical workflow. There may be calls being made to patients, but there's no structured process guiding those interactions. There's no escalation process when a patient reports symptoms or concerns, and there's often no clear documentation logic tied to patient outcomes. Without structure, the program becomes inconsistent and difficult to manage. And when that happens, providers may begin to believe that CCM simply doesn't work. But the reality is the program itself isn't failing. The way it is being implemented is. Another issue I see is when CCM begins to be treated primarily as a documentation exercise, the focus becomes checking boxes for billing rather than actively managing the patient's chronic condition. You may see notes documenting that a phone call occurred, but there's no real tracking of whether the patient's condition is improving. There may be no continuity in the care plan. In some cases, there isn't even a clearly developed care plan at all. There's also little coordination with other providers involved in the patient's care. When that happens, the program loses its clinical value. Managing patients with multiple chronic conditions requires clinical judgment. Patients may report symptoms, medication concerns, or complications that require someone who understands the clinical implications of what they're describing. Certain situations require clinical expertise. When patients report new symptoms, medication issues, or changes in their condition, someone needs to recognize what needs to be escalated to the provider. This is where the conversation about staffing becomes important. Another question that comes up in many practices is whether chronic care management should be handled by medical assistants or whether it should involve nurses. Medical assistants can absolutely support administrative workflows, but chronic disease management often requires clinical assessment and decision making. Nurses bring clinical training and experience that allows them to recognize changes in a patient's condition, reinforce education, assess symptoms, and communicate effectively with providers when something requires attention. That level of clinical insight strengthens the entire care team. For chronic care management to work effectively, it needs structure. That structure includes clearly defined workflows for patient enrollment and outreach and engagement. It includes escalation processes for when clinical issues arise, structured documentation that tracks patient outcomes, and clinical oversight to ensure that patients have a patient centered care plan and are actively working toward their health goals. When those elements are in place, CCM becomes more than just a service that is billed. It becomes a structured system for managing chronic disease, reducing hospitalizations, and improving long term health outcomes for patients. And that's exactly what these services were designed to do. Documentation alone does not improve outcomes, clinical oversight does. If your CCM program feels messy, inconsistent, or difficult to manage, the problem usually isn't the billing code, it's the structure of the program. When workflows, staffing, and clinical oversight are clearly defined, chronic care management becomes one of the most powerful tools available to primary care practices for improving patient care. If you're a nurse who wants to learn how to implement chronic care management and partner with primary care practices, I teach nurses step by step how to structure nurse led care management businesses inside my mentorship program. You can also join my online school, Empower Care Academy, where we have a growing group of nurses in care management